All right. Good morning, everybody, or good afternoon. My name is Amna. I'm a medical student, fourth year medical student from Hofstra Northwell in New York, visiting Loyola. And today I'm going to be presenting to you a challenge. So we have our teams ready, and as I ask questions, I also have sweet treats for whoever gets the question correct. So you'll see soon. And this presentation would not have been possible without Dr. Alam, so just wanted to shout out Dr. Alam for all his help. All right, so HPI, we have a 76-year-old female with a past medical history of lumbar spinal stenosis, prior L5 to S1 fusion in 2011, post-laminectomy syndrome, hyperthyroidism, bilateral adrenal adenomas, and obesity, who presents for evaluation for chronic back pain for more than 17 years. And there's no other pertinent surgical, family, or social history. Okay. So who wants to start off and tell us what type of scan we're seeing right now? Correct.
There's increased focal uptake in thoracic.
Nice.
The uptake in the lumbosacral region, yes, is surgical because in the sacral region, the metric one is really high, but that doesn't usually align with how infection or metastasis presents. But the one in the mid thoracic is asymmetrical, and the margins are kind of weird. It doesn't align with what you would see.
Right. And if you could name the sign, what would you call it? Or what shape does it look more like?
The one in the thoracic?
Yes, the one in the thoracic. Okay, no worries. So this is called, does anybody else have an idea? This is called the Mickey Mouse sign. And we'll talk a little bit more about what sign this is is characteristic of. So this patient had another important scan for this diagnosis, which is a fill in the blank. So who wants to take this? Yes, George. I'm sorry?
Vacuum disc canal.
Can you explain a little bit more about how you got to that? Okay. That's a possibility, but that is not what is going on here. You said that can you explain exactly what you're seeing within the vertebrae?
Second one from the top.
Okay. And is there anything else on your differential? Okay. We do see like vertical lucencies, which can also signify possible hemangioma. That could also be on the differential. But tying together this patient's back pain history as well as the prior bone scan, what we're seeing here is a picture frame sign, which is Does anybody know what that is characteristic of? Yes, Paget's disease. So this is the picture frame sign characteristic of Paget's disease, as well as the Mickey Mouse sign, which is a very rare complication of Paget's disease that we're seeing in this patient. A little bit about the picture frame sign. In the spine, during the mixed phase of Paget disease, we have cortical thickening along all four margins of the vertebral body cortexes, and this produces a picture frame appearance that we're seeing here. We're also seeing disorganized trabecular mesh here, and as well as flattening or squaring of the anterior margin of the vertebral body. So shout out to Sid and George, and I will be, sorry, I forgot your name. Aaron, okay. I will. And Aaron? Sorry. Okay. Alrighty. So we're going to go into the stages of Paget disease. Paget disease has three main stages, as well as one stage at the end that is malignant degeneration. So the first stage is the osteolytic phase. And as we know, there are two types of cells in the bone. One are osteoclasts, which help break down the bone. And then you have osteoblasts that reform bone. So in the osteolytic phase, we have osteoclasts that are breaking down the bone. In the mixed phase, we have osteoclasts that are still elevated. And then we also have osteoblasts that come in and form bone in a very disorganized fashion. They're just laying out collagen in a very disorganized fashion and a lot of hypervascularity. And then in the osteosclerotic phase, we have the overtake of osteoblasts. And then the last phase is malignant degeneration. And these are the three main stages. So going through each phase based off of imaging. So here we're seeing the osteolytic phase. And in the osteolytic phase, what we have is osteolysis that starts within the epiphysis and travels to the diaphysis. And this forms a blade of grass sort of appearance with this radiolucency here in the center of usually long bones, but it can occur in the pelvis as well as small bones in the hands and feet. So this is the blade of grass sign. And blade of grass sign also makes bone more susceptible to fractures, which we're seeing here as well. Then we have the mixed phase. And the mixed phase, as we mentioned, is the combination of both the osteoclastic activity as well as the osteoblastic activity. So you can imagine this leads to very disorganized and irregular bone. And heterogeneous bone that we're seeing. So here we're seeing sclerosis of the iliopectineal and ischiopubic lines and enlargement of the pubic rami and ischium. And then in this bone right here, we're seeing that trabecular enlargement and disorganization, as well as coarsening and thickening of the cortical bone as well. Okay. So now I talked a little bit about picture frame vertebra, but a lot of things can look similar to one another. And so this slide is to help distinguish between a few different diagnoses. So out of these four, which one is the picture frame vertebra that we just discussed? Excellent. A. Oops. So this is our picture frame vertebra. We're seeing the thickening of the cortex on all four sides. And then, does anybody know what B is? Here's your hint. It's a sandwich sign. So the sandwich sign is a radiologic appearance in which the end plates are sclerotic, and that resembles a sandwich. And this is characteristic of osteopetrosis. And for C, does anybody know what this could be? And a little hint is this rugger jersey sign or rugger jersey shirt. And this is characteristic of renal osteodystrophy or hyperparathyroidism. So tertiary hyperparathyroidism where you have low calcium levels. So you can imagine you have low hydroxyapatite. And so the bone is being formed with low levels of hydroxyapatite, which leads to this sclerotic, lucent sclerotic sort of image. And that's the rugger jersey sign that we're seeing here. And lastly, does anybody have an idea what this could be? This is the ivory vertebra sign. And this refers to diffuse and homogeneous increase in opacity of the vertebral bodies. And this is most common with malignancies like lymphoma, but it's actually also common in Paget's disease, specifically in the blastic phase, which we'll talk a little bit about. Speaking of which, this is the blastic phase. And the blastic phase, as we mentioned, is the predominance of osteoblasts. And here we're seeing in the distal fibula, the sclerosis. And on the x-ray here, we're seeing thickening of the right clavicle. And this is indicative of very thick bone and thick and sclerotic bone that is not strong, and also very susceptible to fracture. So in terms of the blastic phase, this is where a lot of the damage happens. We see here bowing of the leg, which happens due to lateral displacement of the femur relative to anterior displacement of the tibia. The tibia, which leads to this characteristic bowing appearance of the shin. And those types of deformities make the bones susceptible to what we call a banana fracture, which is what we're seeing here. Does anybody know who this is on the left side? That is Beethoven, who is famous for losing his hearing, and it was thought to be secondary to Paget's disease because on autopsy he had a really large skull, as well as sclerosis of his ossicles in his ears. And this happened secondary to Paget's disease, specifically in the last stages of the disease, where you have sclerosis of the ossicles as well as narrowing of the internal auditory meatus, which leads to compression of cranial nerves and specifically the cranial nerve 8, and subsequently hearing loss. For our final exercise to see how well you guys have learned, we are going to discuss skull deformity secondary to Paget's disease. So these are 3 different skulls that arise in the different phases of Paget's disease. So speaking of osteolytic phase, which is the first phase, also to keep in mind that these phases do not happen in a linear fashion. You can always regress back to the prior stage. But if we are speaking about a linear fashion, which phase of the skull is the first osteolytic phase? Sorry? Yes, C. And why do you say that?
There's like hypodensity that the hairs are pointing to in the anesthesia.
Exactly, right. So we have the radiolucency, mainly of the frontal bone and the occipital bone. Does anybody know what this is called? Called osteoporosis circumscripta, sorry. And that is mainly seen in the osteolytic phase, as we discussed. And then for the blastic phase, the mixed phase, what do you guys think, which image belongs to that? Why do you say that? Okay, great. That's excellent. So yeah, we see this, what it's called a cotton wool appearance, where we have these dense areas of sclerosis along with areas of lucency that gives this sort of cotton wool appearance. And then Sid mentioned that A is the blastic phase. And this is known as the Tam-O'Shanter sign. And the Tam-O'Shanter sign is marked by thickening of the calvarial table that produces marked enlargement of the diploic space. And that's what we're seeing, this thickening here at the frontal bone. And these are the rest. It's a great job. And I think you guys have learned Paget's disease well. And lastly, I just wanted to put this interesting sign. Abraham Lincoln grew his beard after a 7-year-old girl told him all the ladies like whiskers. And here we're seeing Paget's disease. This is mostly in the mixed and blastic phases. This black beard sign that is characteristic of Paget. So something to keep in mind, basically just enlargement of the mandible that we're seeing increased uptake in. And of course, radiology is not without labs. And so while bone scans are very sensitive and x-rays and radiographs are very specific for Paget's, elevated ALP with normal calcium phosphate and PTH to rule out other causes like hyperparathyroidism are indicative of Paget's, and also urinalysis for markers of specific collagen degradation products, which aren't relevant entirely to you guys, but just something to keep in mind. And then complications of Paget's disease, very importantly, is the malignant degeneration phase that we were talking about. So here we see lucency in the femur here. sorry, in the distal portion of the humerus, distal portion of the humerus, and we also see an associated soft tissue mass. And on the corresponding transverse CT, we see this sclerosis of the bone as well as areas of lucency that is characteristic of Paget's disease. And so this is malignant degeneration of this distal humerus into osteosarcoma. Importantly, another complication is high output cardiac failure, and this is due to the failure of formation of AV shunts within this new bone or disorganized bone that forms, and this leads to an overall increased blood flow. And those are my references, and thank you for listening.
CT scan, that is vacuum disc phenomena. So there was degenerative disc disease, but that was like a secondary finding. The main thing was the picture frame splitting pressure.
All right, so for those who came in a little late, buzzers are on the table, so when the presenters ask the questions, you can get handy.
Your team, your team and your team tied, I think. So.
All right.
Thank you.
Joey.
No, these are really you guys.
These are what?
Oh, that's no, these are like satin headscarf. I'm trying to get into this. I'm trying to grow my hair. Why? I need some change in my life. I either gotta bleach my hair.
All right. Hi, everyone. My name's Joey. The name of my presentation is Belly Button Blues. So just a little history. We have a 73-year-old gentleman with a history of severe COPD presenting with nausea, vomiting, and unrelenting abdominal pain. To the right here, you can see a plain film of his abdomen. So can anybody tell me what the pertinent finding is?
Quadrant could be like a $1 obstruction.
Double wall sign?
Maybe.
Did you see a double wall sign?
In this case, you would not see that. But yeah, very good. Basically, it's just multiple loops of dilated small bowel. And then what would the next best imaging study be? All right, so you get a CT, and then you see this. What are the pertinent findings here?
There's small pulsar of gas along the small bowel walls, so concerning for like pneumatosis intestinalis.
At least you get a deep kind of.
Oh,
Seeing. Not really sure what's in the right lower quadrant on that.
is there like twisting of the mandatory kind of thing?
It looks like dilated small bowel loops again, and then that's ascending and descending fluid.
Yeah, so the findings were some dilation of the small bowel measuring up to 3.5 centimeters. And then, like you mentioned, there's some decompressed colon and ascending and descending, a little more distally. And then here's some videos, might make it a little more clear what's going on. So what do you guys see here?
Transition point at the where it enters the hernia palpitating.
Yeah, very good. So you see periumbilical hernia containing some small bowel. And then you might not have caught it, but there was also an inguinal hernia that you can see there. And so when you're thinking about inguinal hernias, there's two types, direct and indirect. And so here you can see it's on the left side, contains some sigmoid colon. And to differentiate the two, you want to look at the inferior epigastric artery. And so there's a handy mnemonic, MD's lie. So medial to the inferior epigastric artery origin, it would be a direct hernia, and lateral would be an indirect hernia. And then another finding that you may see is the lateral crescent sign. I kind of tried to show it here, but it's a sign of a direct inguinal hernia on CT scan, and it's essentially caused by the compression and lateral displacement of inguinal canal contents. Then here's some MDs lying to patients. And so I also looked into the ACR appropriateness criteria for suspected small bowel obstruction. So if you've ever seen ACR appropriateness criteria, essentially they give different scenarios and then make recommendations for imaging based on that. So this scenario, suspected small bowel obstruction, acute presentation, aligns really well with our patient's presentation. And so it would have been recommended that he had a CT abdomen and pelvis with IV contrast. However, the ordering team got it without IV contrast, which still may be appropriate, but instead they opted for oral contrast. And so oral contrast is not necessary to diagnose small bowel obstruction, but a lot of surgical services do get it to attempt something called a gastrographin challenge, in which they give water-soluble contrast in order to try to resolve the obstruction. However, in this patient with a known hernia and signs of obstruction, it wasn't really necessary. And then also, IV contrast is recommended because it can help show signs of hypoperfusion and ischemia, whereas with oral contrast, it might obscure the bowel wall, and so you wouldn't be able to see that. So some risk factors for hernia, as you can see, there's a laundry list, but essentially it breaks down to two main categories. Risk factors that weaken the abdominal wall, such as obesity, pregnancies, previous abdominal surgeries, heavy lifting, etc. And then also risk factors that impair normal healing, such as diabetes, smoking, use of steroids, etc. So the etiology of hernias has actually been documented as far back as 500 BC, when Hippocrates described them as a rupture of the abdominal wall. But today we see that abdominal hernias are seen in about 1.7% of patients in all age groups, but increases to 4% in patients 45 and older. And then also, inguinal hernias are much more common, making up 75% of abdominal wall hernias, with men being more at risk. But for umbilical hernias, it's much lower percentage at 6%, but it's more commonly seen in women. And then the risk of incarceration or strangulation for periumbilical hernias is about 1 to 3% over the lifespan. So going back to obstruction, CT is much more sensitive than radiographs for diagnosing this, and it often identifies the cause in about 80% of cases. And then some key features you may see on CT are dilated small bowel loops, and there's a handy rule called the 369 rule, in which you want to see the small bowel less than 3 centimeters, the large bowel less than 9 centimeters, and the cecum less than, the large bowel less than 6 centimeters and the cecum less than 9 centimeters. And actually, literature shows that the small bowel really shouldn't exceed 2.5 centimeters, but that doesn't fit in this handy rule. And then also, you might see normal caliber or collapsed loops distally, as we saw in this patient's case. And then you can also see, it's covered by this image, but you could see the feces sign, which you can see in this right-hand corner. And actually, recent literature also shows that this is more commonly seen in non-obstructed bowel, but it could also clue you into a bowel obstruction as well. And then features of strangulation would be thickened or increased attenuation of the bowel wall, halo or target sign, pneumatosis intestinalis, which can lead to portal venous gas, and there's a picture of pneumatosis in this picture here, and then localized fluid or hemorrhage in the mesentery. And then just to go over some surgical options, essentially you can either get a prosthetic repair in which they suture this prosthesis to the abdominal wall, and that could be either open laparoscopic or robotic assisted, or the tissue suture repair in which they just suture up the fascia and hope that it doesn't reopen. And then I looked at one study, the tissue suture repair had a lot more complications than the mesh repairs, and also had greater risk of recurrence of the hernia. And so ultimately for this patient, he needed a ventral hernia repair. He got the open mesh repair, and then in the op report, the surgeon noted that there was no signs of bowel strangulation or tissue necrosis. The patient was observed for 48 hours and then had an uncomplicated course. And that's it.
Any questions?
I think that someone brought up like pneumatosis because there were some bubbles of gas and purely in the small bowel. But to me, that looked more like the string of pearl sign, which is what you see with small bowel infections, where it's related to the obstruction. Small bubbles of gas get trapped in between the valves, like not vented. So you have to try to differentiate those two, string of pearls versus pneumatosis. And with pneumatosis, it's often more diffuse along the posterior wall as well. So that's a helpful differentiating.
Yeah, I agree a little, sometimes hard to distinguish.
Like all the same process like within the membrane itself, like the gas traveling the mucosal layer, or is it
That would be within the wall of the small bowel.
It's
While the string of pearl sign is within the lumen.
right. So the huge process that has multiple bubbles that we can see perhaps they're playing within the actual wall.
Sorry, I'm having trouble here.
It's not important.
No, you make a good point. Yes. So one is in the wall, one is in the lumen.
Right.
But the difficult part is they're so close together that it's sometimes super difficult to say it's in the wall or lumen. But you have to sometimes use others to help you out, like the diffuseness of the process. Thank you.
All right, go ahead.
Okay.
Hi, I'm Alicia. I'm also a fourth year med student. I'm visiting this month from the University of Toledo in Ohio. And for my case, I didn't want to give too much history because I think it would have made it really obvious. So we're just going to start with a 4-year-old boy with no medical complaints. And this little meme is courtesy of Dr. Alam. I wouldn't be bold enough to put that on the slide. Okay. So this is going to favor whichever team has the most CT, I guess, but just go slow. Oopsies. Anything? We'll go back up here.
Yeah, why don't you go slow through the area of interest?
Yeah. And I have different views. Since this one is the hard one. Like anything like right there.
Like, so
Why is this kid getting sick? Is he short of breath?
No, he has no complaints. He's healthy. He was going for just a 4-year-old well check. I promise that's the truth.
And somehow he ended up with it.
And somehow, yeah. I'll go to the next.
Just one.
No, you're good. Sorry, what?
Can you-
You want me to go back to the X?
just let him-
Oh, okay. It's pretty fast. I,
go.
it's a little easier to see.
Oh, yeah.
Yeah. there. So, and I can show it on the axial. I'll go back to, but yeah, like right there, you can see the narrowed portion of the aorta. And then I also took, I think, a screenshot of just this one that makes it very clear to see right here, but I can go back just for how it would be seen here. So like right here, I think is when it's at its narrowest point. And then it gets larger for the rest of the chest. Okay, so I wasn't lying. He was there for a routine healthcare exam. But then as his pediatrician was examining him, she noticed that he had elevated blood pressure that remained elevated in both arms after rechecking 20 minutes later. So she went ahead and ordered an EKG that showed some possible left ventricular hypertrophy, which led to ordering an echo that was a little bit limited by his movement. So she sent him to cardio, who found a murmur and noticed that he had blood pressure differential between his arms and his legs. So some questions for you guys about coarctation of the aorta. This is more boards focused style questions. So what is the most common associated abnormality? That's for the, okay, well, that's the syndrome. For the second one, no, you're good. And then just another, I think there's a hint, yeah. Another cardiac abnormality. Yeah, bicuspid. And that occurs in 80% of cases. And what is the common associated intracranial abnormality? There's your hint. Yeah, berry aneurysm. So we worry about rupture later on. And for Turner syndrome, it's the most common associated syndrome that occurs. It occurs 15 to 20% of the time it's present. So when we're seeing coarctation on imaging, we characterize it. So in this case that I presented, his occurred distal to his left subclavian. So he had actually the adult form, which occurs distal to ligamentum arteriosum and causes that differential blood pressure on the arms and the legs. And usually the arch is completely normal, as opposed to the infants that we see who present shortly after birth and have signs of congestive heart failure and usually have a hypoplastic arch. So even though he was a 4-year-old boy presenting, he was still categorized under the adult form based off of where his stenosis was. So can somebody tell me what the orange arrows are pointing to? Yeah, so they're, yeah, the engorged intercostal arteries. And then can somebody tell me later on, if you are having those engorged intercostal arteries, what specific finding we can see on imaging? Rib notching, yes. And do you know the name of the sign? Anybody? Okay. No? Oh, I thought you were going to guess it. Okay, so it's Rosser sign. So that's the sign name is specific for the rib notching caused by coarctation of the aorta. And it typically, some of the online, it had some different number ribs for which ones are prominent. Some said 2 to 8, some said 4. But regardless, ribs 1 and 2 are excluded because they get their supply elsewhere. And rib notching is something that takes a long time, and we usually typically don't see it until they're, I guess, just as long as they're not children, but usually in adults. And the case I presented, the kid did not have any rib notching on his imaging. So from the increased blood flow in the intercostal arteries becoming engorged, and over time, just put pressure on those ribs running underneath, and it'll cause that little divot looking. Is that correct? And then the other big imaging sign is the figure of 3 sign. And as it's marked out, it's just from where we see dilating before the coarctation and then the narrowing from where it's at its narrowest point and then dilating afterwards. And that one we can just identify beforehand on x-ray. So specific to This case, he underwent surgical repair 6 weeks later at an outside facility, and he had the end-to-end repair where they just resected that portion and made an anastomosis between the other two ends. But also another commonly used treatment is the balloon where they just inflate it with that. And the subclavian flap, I think, is less commonly used. And he then underwent a short-term course of diuretics and an ACE inhibitor. And at his follow-up 2 months later, had a completely normal exam, no more murmur, normal blood pressure everywhere. And that's that.
You guys need to.
Because I'm waiting for the sun to go down a little bit. I don't want to, because it increases.
Is that when my son's starting?
And I'm not switching.
Okay, hi, I'm Elizabeth and I'm an M4 from Loyola. A brief clinical history about my patient. They're a 9-year-old male with occasional complaints of left shoulder pain. Otherwise, they're active, they're physically well, no known history of trauma, and no known medical conditions. So to start, we got an X-ray if anyone wants to describe the abnormal finding here.
You can use your butters as well.
Let's just say it's not a well honed down image.
That's not impressive.
Is that supposed to be just X-ray or or an oval scan?
Actually, it was a whole body X-ray scan, but the area is around here.
The whole face?
Does he have some sort of like Klippel-Feil? No, you're thinking it all. There's like left scapula.
Yes, yeah, exactly. His left scapula is significantly higher than the right scapula. Also got an MRI.
On the PowerPoint too.
Click the enlarge button and run right now. There. Oh.
Does anyone see an abnormality here?
It's like a pretty like central to the cord.
That's just like artifact from.
Like if you saw that.
No, exactly. Sorry, I'm going to restart this. This is a hint to what the name of that structure is, if anyone knows what that's called.
Yeah, Saturday night coffee. No.
Oh my God.
No.
You deserve candy for that. You deserve candy for this.
It's called an omovertebral bar. And this is a 3D representation from the MRI of what this looks like in our patient, and a good representation in this little tree figure. It's a congenital abnormality that connects one scapula up to the cervical spine here. And there's a few other abnormalities on the MRI, so I have a sagittal view if anyone can point them out. Yes, there's a syrinx. And then there's one other thing. Just kind of hard to see on this view. But there is a partial fusion of C4, C5 here, which is a congenital fusion. Does anyone know what syndrome has all of these findings? No. It's called Klippel-Feil syndrome. It's a very rare congenital disorder characterized by the fusion of two or more cervical vertebrae, and it's associated with a wasp waist sign on sagittal view. And here's a better image of what this looks like, just where the joint that's effective has a smaller diameter than the unaffected joints above and below it. This syndrome is associated with a clinical triad of a low hairline, a short neck, and also limited range of motion in the neck. But patients rarely have all three, and it's pretty common for patients to have no symptoms and have this be an incidental finding. It's associated with many other congenital abnormalities, specifically Sprengel's deformity of the shoulder, which is that unilateral shoulder elevation that we saw. And the full cause of this is not fully understood, but there is a genetic component that they sometimes ask test questions about. For a single level fusion, there is a autosomal dominant component, and for the lower C5 to C6, there's a recessive component. And so an easy way to remember this is that the dominant is above or on. And it's named after two doctors, Dr. Feil and Klippel. I had never heard of them before, but I did a little research when I was doing this project, and it turns out that Dr. Feil did a lot of work on cervical abnormalities and was attributed to having a social transformation in medicine, just transforming how they interacted with patients with congenital abnormalities, which is pretty cool. In terms of treatment for this syndrome, it's frequently just conservative symptomatic treatment. If they have neurological symptoms from the cervical abnormalities, they may do surgery, specifically if there's any myelopathy or radiculopathy. But any patient with a fusion at C3 or above is recommended to avoid contact sports and modify their activity because there is a higher risk of cervical spine injury. And if there is one of these types of injury, it can cause symptom progression, specifically those neurological symptoms. In terms of the shoulder deformity, this is often associated with Klippel-Feil and other congenital syndromes as well. And it is just a elevated scapula unilaterally. And for some patients, they will also have formation of this omovertebral bar, as we saw in this patient. And this connects the elevated scapula up to the cervical spine, and it can be fibrous, cartilaginous, or osseous, and essentially form an accessory bone. But it can also be a combination of these three. And so for Sprengel deformity, you can typically see it on X-ray because there is a pretty prominent asymmetry. But if you want to evaluate if there is an omovertebral bar, CT or MRI is best. And surgery can be performed in order to make cosmetic correction or to limit functional disability if they have very limited range of motion. And a fun fact about Sprengel's deformity is the actor that played the Joker had a known Sprengel deformity. In terms of this patient, they were offered surgical intervention for their shoulder because they had very significantly decreased range of motion, 90 degrees to compare to 180 degrees on the other side. But the family decided to seek a second opinion because the patient's pretty asymptomatic and very active. So they're still deciding if they want to pursue that. These are my references. Thank you.